Welcome to Healthbeat, BKCSA's monthly television program that takes an in-depth look at health issues. I'm Mia Malan. In 2012, a team of pharmaceutical researchers developed Semaglutide, a once-a-week diabetes jab. It was given the brand name Ozempic and lowered the blood sugar levels of people with type 2 diabetes, one of the fastest growing diseases in South Africa. More than a decade later, there's been a months-long global shortage of Ozempic because doctors now also prescribe it as an appetite suppressant for people wanting to lose weight. This has caused a bit of an outcry, with some experts saying healthy eating and diet should be the way to go. But a growing group of scientists argue that diets and exercise don't work in the long term and that obesity is a chronic disease that requires medical treatment. So, should Ozempic be used for weight loss purposes or not? And does it really work? Journalists Mohali Malloy and Yolanda Mtzeke spoke to two Ozempic users who believe it does.
So my sister got married in 2018 and, being the supportive sister and our chief bridesmaid, we were waking up at 4 o'clock in the morning, 5 times a week. We're boxing. Our cousin was in there too. It was hectic. And I felt like I was training for the army.
Nomathemba Chandiwana is an HIV and obesity doctor at the Izinja Research Center in Johannesburg. An intense exercise routine helped her get in shape for her sister's big day 5 years ago.
And it was not sustainable. So we're able to do this for 3 to 6 months to fit into that dress. You fit into that dress, life goes back, your weight goes up again.
For some, weight is a deeply personal, lifelong issue, and it's not always easy to talk about.
Like most women, I've struggled with weight from the time I was a teenager.
When Nomathemba's patients started picking up 15 to 20 kilos, she went looking for ways to help them. She read studies about a class of medication that mimics a naturally occurring hormone called GLP.
So GLP is something that's naturally found in the body, in the gut. We've got this class of drugs which are GLP agonists, liraglutide, semaglutide, popularly known as Ozempic at the moment. So these are a class of drugs that were used for diabetes management. But they found that people who were using this for diabetes, that they were losing weight as well. So at higher doses, they're used for weight management. And they work simply by delaying the food in our gut, and you feel fuller for longer. So then you eat less.
When Nomathemba gave this drug to patients and saw how well it worked for them, she wondered if it would work for her too. So she consulted an endocrinologist, began taking Ozempic, and she's lost the same amount of weight as when she was dieting.
On the GLP agonists, I've also lost about 9 kilos. I've changed nothing. I'll be honest, I hardly exercise. I take a daily walk with the kids and the dogs. That's about it.
This jab hasn't only helped Nomathemba. Gillian Swan says Ozempic gave her a new lease on life when illness cut short her tennis career.
4 years ago, I had a hip replacement. And the reason for my first hip replacement was osteoarthritis. And then I had my baby, so I carried a baby with a hip replacement. And then last year, May, was where I started taking the injection because my weight was just too much. I had to bring it down. It just couldn't, my new hip couldn't carry me.
She put on more weight after a second hip replacement last year, so she consulted her doctor.
She said, you just have to start exercising and eat healthy. I'm active, eat healthy. I've tried with nutritionists, dietitians, it just didn't work for me.
With her weight at 110 kilograms, Gillian got herself onto Ozempic. She's shed 25 kilograms and feels a whole lot better.
When you are carrying the weight that I was, it's almost like you sit there and everybody's going, oh God, what is she eating now? And it really did take a toll on my confidence and who I was.
Both Gillian and Nomathemba believe doctors should rethink how they help patients with obesity. They see nothing wrong with being prescribed Ozempic if diet and exercise alone don't work.
Excess weight, overweight and obesity is a real issue in South Africa. And So I approach it like not aesthetics, but really around what excess weight does for your health outcomes. So we really want to have these drugs available for people so that they can be able to manage their weight and also just reduce their risk of other things in the future.
That report was compiled by Muhali Malloy and Yolanda Mtseke. South Africa's largest medical aid, Discovery Health, says for now the scheme won't be funding Ozempic as a chronic benefit to treat obesity. If members want to use it for weight loss, they'll have to pay for the drug themselves or their medical aid savings plans will be used. Dr. Noluthando Namatswarani is Discovery Health's Chief Clinical Officer. She says obesity requires different forms of treatment for different people.
Towards the end of 2021, going into 2022, first quarter 2022, in the day-to-day benefit space, we saw a 224% increase in utilization of this drug, which then indicates to us that there could be people who are using it, not necessarily for diabetes, but now for weight loss specifically. Our side, we are going to be advocating for Ozempic to be used by type 2 diabetics and not for weight loss reduction outside of diabetes management to ensure ongoing access for patients who require the treatment. Saxenda is, however, registered in South Africa for weight loss, which is liraglutide. So in those instances, it's important also to understand that the registration of these drugs is not as a standalone. It is always in combination with lifestyle modifications. So a healthy diet and exercise program. So my worry is that there could be people who are using these drugs off-label, not in combination with the lifestyle modifications that are required. And also, we don't know the doses that they're using. These are drugs that are meant to be taken on a chronic basis, meaning that it's long-term. So it's not like you're going to stop, because when you do stop, you regain the weight.
That was Dr. Noluthando Namatswarani, who is Discovery Health's Chief Clinical Officer. So can a drug alone end obesity, or are there more sustainable ways of managing weight? With me to discuss that is endocrinologist Dr. Sandeep Ruda, who is in private practice in Johannesburg. Dr. Ruda, thanks very much for making the time to join us today.
Thanks, Mia.
How does the mechanism work? How does this drug get you to lose weight?
It will help to reduce hunger and increase satiety, that sense of fullness. It tends to lower the thermostat for weight regulation. So a lot of people try and lose weight through lifestyle modification, and they will with consistency and effort, but they reach a threshold whereby they can't get beyond that. This is where the physiology of the body fights back through becoming acclimatized to the old higher weight, you see. So the drug will help you go beyond your threshold for losing weight through consistency in lifestyle as well, and set the thermostat down a bit.
What happens if you stop taking the drug?
When you stop the drug, the weight goes up again. So generally it's shown that it goes up, but we don't have long-term data on follow-up of those patients. Certainly if you stop the drug, there's going to be some weight gain.
In addition to semaglutide, there's another drug that you can use that is registered in South Africa. Tell us a little bit about that and side effects.
Semaglutide is not registered for weight loss in South Africa. It is not registered as an obesity. The version available in South Africa is registered for the treatment of type 2 diabetes. The approved drug is its predecessor called liraglutide. The dosage is given as a daily dose as opposed to a weekly dose, and weight loss is in the region of 8 to 10% over a period of a year. Side effects in this class are standardized and we know them. The most common are gastric side effects. So nausea, vomiting, diarrhea are the more common ones. Most patients develop tolerance over a period of a month as we titrate the dosages. But the side effects with the newer ones, semaglutide, are slightly more in the gastric space, but you also develop tolerance if you do it slowly and properly. And then there is in the package insert an allusion to gallbladder issues like gallstones, though they're quite rare. Pancreatitis has been stated. And then there's a package label warning about thyroid cancer as well.
You've got some patients on weight loss injections. How do you choose who qualifies for it?
The drugs are indicated for patients who meet the criteria. Body mass index over 30, definitely. Now, BMI over 27 with a weight-related complication like hypertension, high cholesterol, or diabetes or pre-diabetes. But when prescribing a drug also, we got to first interview the patient, look at the psychological state, access to resources, cost of care, which is a big issue because these drugs are very costly, and you need the patient to be able to afford it for a longer term.
I want to ask about the price, but before I get to that, you mentioned body mass index and how that determines who qualifies for the drug, who can be considered. Can you just break down what is a BMI and those figures that you mentioned, what that indicates?
The body mass index is an index of risk based on your weight in kilograms over your height squared in meters squared. And basically, it's not really an assessment of how much fat, excess fat, the body is carrying. It's a measure of risk. The higher your BMI, the more at risk you are of all the complications of obesity.
And what does your BMI need to be if you want to qualify for this drug?
So according to the guidelines currently, body mass index over 30, which is classified as obesity, qualifies. A body mass index of over 25 is overweight, but 27 or more with a complication like cholesterol qualifies as well.
To get back to price, what does it cost per month to get this type of injections? And do people stay on them? Do they manage to take them consistently?
So I can tell you with the approved obesity GLP-1 receptor agonist, which is liraglutide in this country, which we've been using for some years now, it's been available and registered for obesity. The current cost out of pocket, and it's not covered by funders, is between 3,500 to 4,000 Rand a month. We see dropout rates because of, after a while, it's unaffordable. So after a year, most patients are starting to come off the medication or they feel I've reached my weight loss goal. Reported rates in trials are around 20 to 30%. So that's quite a high dropout rate. In clinical practice, it's probably a bit higher. Patients get a bit tired of the nausea if they haven't acclimatized to it.
And just to clarify for our viewers, the semaglutide injection for weight loss you're referring to is Wegovy, right? That is not yet
That's
registered
the trade
here.
name abroad, yes, correct.
Dr. Ruder, thanks very much for making the time to talk to us today. That was endocrinologist Dr. Sandeep Ruder, who told us more about the weight loss injection, Ozempic. But how can we as a nation reduce obesity when the most accessible and cheapest foods are also often the most unhealthy and fattening? Let's find out from public health expert Professor Susan Goldstein from Priceless South Africa, a medical research council project. What kind of burden does obesity place on our public health system?
Thank you for that question, Mia. The burden is not only financial, which is huge, 13.2 billion Rand in total on our public health system, but the burden is also on individuals and families. And the reason for that is obesity causes diabetes, it causes hypertension, cardiac disease, and people end up not being able to work. They end up disabled because they have a stroke or they have an amputation from diabetes.
Let's look at solutions. We implemented sugar tax in South Africa a few years ago. What is that exactly, and does it really work?
So the sugar tax, sugary beverage tax, to be accurate, is now called the Health Promotion Levy. And the idea behind the tax is that sugary beverages have absolutely no nutritional value whatsoever, but they cause huge obesity. So a child who drinks a sugary beverage every day has got a 20 times greater chance of becoming obese. So what was introduced was a tax that taxes, you allowed 4 grams of sugar before it is taxed per 330 mils. and then the government taxes an increasing amount, incremental amount, however much sugar there is in the drink. Is it working? Well, yes and no. So the government didn't implement the full tax that was recommended, but it is working to a certain extent. People have stopped buying as many drinks, sugary beverages. People, especially poor people, are doing better because they're having less of these drinks.
So if we look at foods and snacks, for instance, such as crisps and slop chips and quarters and vet cook, should those foods be regulated, or is it really just about awareness?
No, absolutely should be regulated. So the way that we've been thinking about it is that we talk about ultra-processed foods. So if you think about foods in boxes, anything that comes in a box is usually processed. And it's processed in a way that tries to make us want to eat it. So it adds sugar, adds salt, adds fat. And those things are really bad for us. So what we're trying to do is saying, don't eat those things. Eat something that you buy and cook, or you even eat raw. Because those things are what's really harmful to people's health. And that's what has created this massive obesity problem in South Africa.
But how do we regulate them?
So we're trying in a number of ways. The first way is to stop advertising of these foods, particularly to children. So we've done some research, and children are advertised these foods all the time. And it's not only advertising on television and radio, but it's things like KFC cricket, for example. We're talking about characters, cartoon characters on the front of cereal boxes that have loads of sugar in them. So trying to ban advertising of these things to children is a start. The way to do that, however, has been complicated, because then the government says, well, how do we know which are the bad ones and which are the good ones? So there's been a concerted effort and a development of a regulation which will label the packets, the front of packs of these particular foods, which will tell us this food has too much salt, this food has too much sugar, this food has too much fat. And so the idea is that then we know anything that's got a label on cannot be marketed to a child.
Is there evidence, because I know the health department has published draft regulations for this, and I think it's by 2025 that we need to see the labels. Is there evidence from other countries that this labeling really works? Do people listen to it?
There is evidence. Chile and Mexico have done it, and they show quite good evidence that it decreases the amount of packaged foods that people buy. It does wear off a little bit after a while. But what is encouraging is that people, the producers, the industry, reformulates the food to try and avoid the labeling. So they'll try and decrease the amount of sugar, try and decrease salt and fat. And that's, of course, a benefit because it's healthier.
I want to relate this a little bit to the South African situation, because a lot of these foods don't come packaged. They're sold in informal markets or along the street, for instance, vet cook, quarters. How do you regulate that?
You can't. The short answer is you can't. But what you should be doing is looking at improving the food system. So what we have is we have a food system that's dominated by industries, big industries, and we're talking about multinational companies. But what we really need is a food system where local people farm and sell their produce locally, and those produce will be healthier. Having occasional vet cook is not bad for you. Having occasional quarter is not terrible for you. But if you think of what goes in the quarter, there's processed foods in that quarter. So the polony, all those kinds of foods. We really need to rethink how we have food in our society.
To move back a little bit to medication to treat obesity, the United Kingdom's public health system recently recommended the weight loss injection Wegovy, which has the same ingredient as Ozempic semaglutide. What do you think of that strategy, and do you think South Africa should follow suit once Wegovy is registered here as well?
So that's an interesting question, because I think that it's like any illness. Obesity needs to be treated. So people who are obese need help. to decrease their weight. And we know diets do not work for any length of time. But I think the problem with it is the opportunity costs. So what that means is for every injection that we buy, which are going to be very expensive, by the way, we are losing the opportunity for immunization of children against measles or other anti-hypertension treatments. We have to weigh what is most important within our context.
You've mentioned that we need to weigh this up. Are we going to lose money for immunizations if we buy injections to treat weight loss?
Absolutely, we are.
But shouldn't we also look at what we would save money on so people wouldn't get diabetes and they wouldn't need so much hypertension medication? Wouldn't that also count in a positive way?
I think you're quite right. I think that what we need to do is do the sums. So we need to look at what is the cost of this new injection, and we need to look at equity. Who is going to be able to get that? My suspicion is that it's going to be only the wealthier quintile of people, and poorer people probably end up not getting it. But we need to weigh it up. We need to actually look and see, okay, what would the cost savings be and what would the actual cost be?
To end with basic foods, the Competition Commission's Essential Food Price Monitoring Report has found that prices for essential foods such as sunflower oil, brown bread and maize meal were unjustifiably increased by retailers in 2022. How should we regulate grocery stores so that unprocessed foods aren't cheaper than essential foods?
Yeah. It's a difficult question, and I think it harps back to what I said earlier about our food system. At the moment, the food system is controlled by very big industries, and the whole supply chain is controlled from the farmer to the grocery store, basically controlled by a very small group of industries. What we need to do is open that up and make sure that it isn't controlled. There isn't this price fixing. It's horrific. Can you imagine in a context where 40% of people go to bed hungry, there's price fixing about basic foods? It's totally shocking. So we really need to rethink the whole food system.
Professor Goldstein, thanks very much for joining us today. That was Professor Susan Goldstein from Priceless South Africa at the Medical Research Council. That's our program for now. Till next time, goodbye.